Hello, I'm Dr. Peter Lio. I'm a clinical assistant professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine in Chicago, Illinois, and this is Grand Rounds for Atopic Dermatitis. I'm joined today by my friend and colleague, Douglas DiRuggiero. Douglas, would you like to introduce yourself?
Certainly. An honor to be here with you, Dr. Leo. I'm a physician assistant. I practice in Northwest Georgia in a town called Rome, where I've been practicing for the last 29 years, and the last 26 of it full-time in dermatology. So love educating, love atopic dermatitis, and looking forward to doing this with you.
Love it. I'm so glad we're together, and I'll jump right in. My first case is a 12-year-old with a history of severe atopic dermatitis since about 3 months of age. This poor patient has really been struggling, trouble sleeping at night due to the itch, and this is now spilling over to trouble at school, concentrating, staying awake during the day, all of these issues, focusing, test taking, everything starting to fall apart. The family history is notable for asthma and atopic dermatitis in the patient's mom and in several cousins. And the PMH is notable for mild asthma, but it's been under control for this patient for a while. He does also have some seasonal allergies in his medical history. They have tried a lot of different medicines, multiple different topical corticosteroids from hydrocortisone, triamcinolone, mometasone. They've done tacrolimus, the non-steroidal topical calcineurin inhibitor, but that they found was kind of uncomfortable. It caused some stinging, and they really didn't want to go forward. We can see here on examination, we're looking particularly at the left leg, and we can see that there is quite a bit of erythema. There's scaling. There's definitely some cracking and fissuring, and you can see some lichenification changes of the skin as well. I would call this an IGA score of 3. This is at least moderate disease here. And the ADCT, something that I really love, the atopic dermatitis control tool, is something that's been really helpful for me in getting a sense of where they're at. We know this goes from 0 to 24, and you want to be below 7 to be considered under control. If you're a 7 or greater, you're actually considered not under control. And this patient got a score of 12. So it's not completely insane, but it's not under control. And we're hearing it from the patient. This is really fitting in that this is affecting quality of life. So what do we do when we see a patient like this? I think for me, the general approach that I want to make sure we're doing, or if they have done something like this, is to build that eczema action plan where I'm going to give them a rescue set of things to do. Typically, that's where I'm going to put my corticosteroid. I'm not anti-steroid. Some people know that I really am interested in non-steroidal approaches, but that doesn't mean it's to the exclusion of steroids. I still really love and I'm grateful for steroids because they are so reliable, they work so quickly, they're very accessible. So I have them do that steroid couple times a day. In this case, or a case like this, we also talked about the power of wet wrap therapy, where we could actually put a damp layer of clothing or gauze to really push the penetration and enhance that treatment for the patient. But I'm going to limit that with time. I'm going to tell the family and tell the patient, we don't want to do this all the time. This is not suitable for long-term use, at least not consecutively. We want to take little breaks. So we would say do this for a few days up to a week. And then when you're better, that's where we could presumably put in our non-steroidal treatment. And that's going to be a way that we can continue to keep anti-inflammatory pressure and keep the skin happy and healthy, but not keep pushing steroids at that point. So I think this is a really nice way to do this. Douglas, do you do something similar for your patients, at least conceptually, when you're talking to them, or how do you go about it?
Well, I want to just echo your thoughts on the steroids. My big phrase right now is I want colleagues to understand and patients to understand the phrase no steroids, meaning KNOW, know what steroids can do, and not no steroids, NO. So knowing about steroids versus no steroids is where I think we want to land. We want to be able to educate each other on beyond cutaneous adverse events, but systemic adverse events to topical steroids. So they have their place. They're bridge therapies. They're calming things down. They're making patients understand that. And wet wraps, I think, is too far forgotten. And I'd like to incorporate that, particularly for a hard hit area like that ankle. That's a pretty severe area. So you may not wet wrap the entire body. You may just do one little area that's just really, really severe. And so I think that that's a good way to have, parents involved.
I love it. If we could just go back to that wet wrap slide, this is a handout that I use for my patients that really shows both of those possibilities. You can do the whole body if you want with like a pajama or with a onesie, but you can also, and very, very important to tell patients, you can do a targeted one, gloves, socks, or just a gauze or a wrap, or even just a damp cloth. I've had patients just kind of take a damp washcloth and just place that over an area while they're watching a show. Even 20 minutes to an hour can be plenty of time to do something. It just cools it and enhances penetration. On the next slide, we can actually see the plan that I gave to this patient because I really wanted to optimize the topical plan. So I went back to mometasone. He had apparently tried that in the past, but they couldn't remember what happened with it. So I said, let's do that. I really have a lot of faith in that particular corticosteroid. It's very inexpensive. It's very reliable. It's been studied down to really young kids. So I feel pretty comfortable about its safety in children. In general, I think steroids are somewhat fungible. You can interchange them, but I have a couple of favorites. And mometasone is one to me that maybe it just punches a little bit above its weight. It's just a little bit better than some of the competitors. And I like that a lot. And then built in the wet wrap. So this is a pretty intensive regimen. And I coached them. I said, I want you to do this for just a few days. And then I want you to call me and let me know because I'm going to follow up. So I saw them on a Monday. They contacted me just a few days later and said, you know what? It's much better. He slept well. We really feel like the skin's turning around. Good. Now we're going to take a break from those strong steroids. Let's go to our When Better plan. Here is where I brought in topical ruxolitinib, one of, in my opinion, the nicest non-steroidal options, one of the fastest working, most powerful. And we were going to put that to those remaining areas or trouble spots until he's totally clear, maintaining all of those other pieces. And with this plan, the next slide, we were able to get a really impressive improvement at
Mhm.
follow-up. When we saw him back, almost clear on the IGA score. The ADCT now is well below 7. It's a 3, sleeping well, very happy, feels like a new person, school's going better. And now they found that they actually haven't even had to go back to the steroid. They still have it, refills on file, they're ready to go, but they haven't needed it. They're just using that ruxolitinib once in a while, usually just a few days each week. I would call this a win.
That is definitely a win. Look at the change. And that allows these kids to engage in sports and to do activities. I mean, there's so many things that eczema limits their life. And so that's nice to see that. I have another scenario that I want to talk through with you and with our listeners. And this is looking at these younger kids. I mean, this is ages 2 months to 2 years old, two different cases, both patients of mine. And I'm highlighting this kind of refractory, thickened, excoriated, lichenified cheeks, on the face. Oftentimes, our primary care colleagues don't think that atopic dermatitis really can present, on the cheeks. They think so much about these antecubital fossas, popliteal fossa. But in this age category, it's common for it to cover most of the upper body, including the face. Parents really want this to be something that is just an allergy to the detergent on the blanket they have, or they're rubbing their face too much. But I wanted to present this because these refractory cheeks, these things are hard to clear. You can get a lot of other areas to improve. When I'm talking about what do we do with these persistent, hard to treat cheeks, kids love to rub them. They scratch, they're rubbing constantly. They rub them on the carpet, they rub them on blankets. They're looking like a bear trying to find a tree. They're trying to rub those cheeks against things because they itch. They're pruritic. They stay moist because of slobber and food, right? That's on the face. And the parents are constantly trying to do things. Remember, you can put the onesie on and cover everything else, but that face is always face forward. So the parents are really concerned about this area. It looks bad, and the onesie can't cover it up. So what are our options in this age category? We're talking about someone under the age of 2. Crystal boral has been approved for 3 months and up. We still have our topical steroids with the appropriate potency. We have a lot of home and integrated remedies that could be discussed. And then, of course, your systemics right now, with dupilumab being the only one down to age 6 months, and systemic steroids. So what I learned from you some years ago and from Dr. Swanson is I have found this Aron regimen to be extraordinarily helpful, beneficial, and highly effective, particularly for refractory cheeks in this young category. Now, I know that Dr. Aron, practicing overseas, and our European colleague has come up with this, and it's been championed by a lot of folks who know it. Maybe others haven't heard of it. Maybe others feel like that it's crazy to think about using against steroids in a mixed concoction for a long period of time. But it's 30 grams of beta-methazone valerate, as you see here, zero point 0.1. You got 24 grams of mupirocin, and I'd like to put it in 400 grams of Vandy cream. And so that makes basically a 1 pound. that diluted, it's important to have that diluted steroid down, and then you add trying to decrease the colonization of potential staph and strep on the skin. And I'll have them use it 3 or 4 times a day for the first 5 days, and then, cut it down, and taper it down. And really, this is something they could use long term. They could use it every day for the next month. I'll typically have them come back in 1 month. You kinda hit it hard up front with a higher frequency of application and then taper down, and this just works beautifully well for me in this category, particularly when I don't find that crystal ball is highly effective, that it does sting and burn, and I don't want them to use a straight out steroid. And if they can get this regimen, have it compounded, there are some places where you can compound. The key I would say to this is that you don't want to just write these as separates. Don't want to write 30-gram cream, another cream, have them mix it. If you can get a compounding pharmacy, because they're mixing the powder version of these things, they blend better, the concentration's better. I see a difference whenever I have it compounded at a compounding pharmacy and put into the hands of the parents for these cases. What are your thoughts on this?
I'm a huge fan, as you know, and I remember the first patient that told me about this Aron regime from this South African dermatologist, Dr. Richard Aron, who was practicing in London for many years and
Mhm,
had this kind of bizarre combination that he would give to his patients. And I looked at it and I said, well, yeah, I'll write it for you, but it's so diluted. I don't think it's going to do anything. You have stronger stuff at home. And the first patient called me a week later. The mom was crying. She said, it's the best thing you ever gave us. And I was like, what did I give you again? And then another family called me and said, we want to try it. So I said, okay, same thing. I don't know if it's going to help. You've got stronger stuff. And then they called me saying it was the best thing I ever gave. And then I said, okay, something's weird for this to work so well. So I totally agree with you. It is a low potency steroid. Honestly, the mupiracin's fairly diluted in there too. So I don't know. I don't exactly know what we're doing, but I can't argue with results. It's one of my favorite treatments, and it really has changed
mhm,
many patients. Both, it sounds like your patients and mine. It's changed their lives for people that have in
mhm.
earnest tried other things.
I mean, you and I both agree, if we can move them towards a steroid-free options, ruxolitinib being a fantastic one, it's just you gotta have different plans in different age categories for different areas, and that's what we're trying to highlight here.
Every pot has a lid, and our job is to find it.
Mhm. Exactly. Well, I've enjoyed this session. Thank you so much for including me in it.
Thank you.